All right, let's begin. Welcome to the 2020 Public Health Law Virtual Summit. We have 2 presentations in this session, and each presentation will be followed by a Q&A. Use the chat feature to submit your question on Pathable. If you encounter technical difficulties during the summit, go to the navigation menu and select the Need Help button. Now, I will turn it over to our first presenter, Patricia Williams. Patricia, take it away.
Thank you. It's a real pleasure to be here and an honor. I am going to talk about the disparate impact of COVID on populations marked as race and the difficulty of disaggregating the markers of race from presumptions of innate susceptibility. There's certainly no question that people of color are dying at disproportionate, completely unholy rates. And I'm assuming that this audience has heard and appreciates that disparity, so I'm not going to spend a great deal of time reiterating those numbers. They are off the charts. At the same time, we of course must know that race is correlated with stresses that are not innate, but are distributed unevenly and unequally because of social factors. And yet we are living in a time when lots of people want to treat race as a proxy, if not an inherency, in the medical profession. And so let me state my belief very clearly to start with. Minorities' lower survival rates could be more accurately described by referring to homelessness, dense housing, lack of health insurance, inadequate food supplies, exposure to environmental toxins in the ghettoized geographies that have become such petri dishes of contagion. And another reduction in this discussion is that this disparity is understood to be one that affects exclusively Blacks and Latinos, but in truth, every category of racial group marked as minority in America, including not just Blacks, but Indigenous, Asians, Latinos, Pacific Islanders, all are more likely to die than those identified socially as whites in the United States of America, and to die from COVID. So this is not to suggest that discrimination suffered by these populations is simply about being poor or simply about class. In a nation shadowed by eugenic histories like the American Eugenics Society and Jim Crow, race is its own risk. American prejudices about color and race are rooted in powerful long-term traditions of anti-miscegenation and untouchability, and the propinquity of dark bodies, sometimes even so much as eye contact, incites anxiety and fear of social closeness, and even to doctors, color can become an unacknowledged source of revulsion if they've grown up in all-white environments. It can operate affectively and aversely, like a sign of stigmatizing witchery, or almost like children's sense of cooties. And you see this even in our infant mortality rates. Black babies treated by white doctors are 3 times as likely to die than those treated by Black doctors. This is not an argument for segregating babies at birth by the color of their doctors, but for really examining the underlying rules or sources of this regard and this fear of handling and of touching and of proximity. Race, therefore, is a particularly bad proxy for biological risk. It is not useful, particularly in the face of this pandemic, and here's why. As far as we know, all humans are vulnerable to COVID-19. To assign race as causal in its spread is a terrible category mistake. Even where certain diseases actually do cluster within particular populations, it is a mistake to describe such clusters as racial. But again, medical history shows that we have a habit of doing precisely that. Humans are susceptible to a whole range of diseases. We often delude ourselves into thinking of as only the property of only particular ethnicities or races, instead of perhaps something like continental origin, which is different. So diseases like Kawasaki disease has a somewhat higher frequency among those of Japanese descent, but it is not exclusive a Japanese disease, as it's sometimes preached, anemia, often misleadingly, fatally misleading, called a Black or African disease, rather than an equatorial or malaria response disease. Or skin cancer. I once heard a television doctor describe somebody, say something like, Black people never have to worry about skin cancer, when Bob Marley, for example, died of skin cancer. All of this shows that even high aggregations of frequency are no substitute for actual diagnosis, and mere correlation is not the same as cause and effect. Yet epidemiological calculations are too frequently used as proxies for individual diagnoses. And it's being built into algorithms and diagnostic machinery that's a setup for a continuation of this kind of racialized tragedy. And so let me use a non-COVID example to clarify the mechanisms of what I mean and the risks of what I mean. And I'm going to use osteoporosis because I have a good example for it, I guess. There is a website, for example, that reads the outcome or that interprets the outcome of bone density scans. And it's a website called FRAX. It's an internationally used calculator formulated in the UK. And it has a calculator, you can actually take a tab down, that is for USA use only, which distinguishes the risk for, and assigns a different value to the risk for US Caucasian from Black, Hispanic, and Asian. It doesn't do that for any other nation on the planet, except I think maybe China, which actually says Chinese and Mongolian, which again reveals, I think, some of the political consequence built into this machine. But to push the point a little bit more, I am a woman of a certain age, and doctors routinely use those two metrics, age and sex, as triggers for testing women over the age of 60 for osteopenia and osteoporosis. And so thus, when I was given a routine bone scan recently, the results that came back to a computer on my doctor's desk were supposed to figure out whether I might need medication using my individual data and predictive algorithms. The doctor sat behind his computer for a very long time, and finally his head emerged rather apologetically from around the rim of the screen, and he cleared his throat and mumbled at the machine, couldn't do the calculation, and then he said, probably because you're Black. And annoyed, but undaunted, I told him just to sabotage that machine by telling it I was white. Now, I was not trying to put a whole racial dolezal or whatever. I wanted to see what happened, who I would be if I had been calculated differently by this algorithm. And based on that simple switch of racial identity alone, the system promptly presented me with a slew of additional questions, like whether I'd ever broken a bone, if so, at what age, whether I showed signs of rheumatoid arthritis, and most urgently, whether there had been osteoporosis in my family, especially my mother. And the fact that that machine would not have asked me any of that if I had been categorized as Black was machine bias of a profound and profoundly disturbing sort. Indeed, although the machine apparently had categorized my Blackness as self-identified, no one had ever asked me about my heritage. And clearly some administrator or nurse had checked the box based on how purportedly and persistently self-evident or obvious race is thought to be within the American cultural, not biological, cultural context. The infinite spectrum of melanin inheritance that is thus reductively seen as, or seen by the machine as an either or. In addition, the authority of my well-trained doctor, a human expert, was superseded by the narrowly closed-loop small-mindedness of a black box containing only the pathways programmed by a non-medical computer scientist who apparently was socialized to think about race as binary, binding, and blinding. And the deference my doctor accorded to the machine, and the deference that most of us accord algorithms, dislocates particularized human expertise. And black box medicine may be great at identifying and assessing broad patterns, but when it comes to the peculiarly complex intricacies of individual bodies in a nation of extraordinarily mixed and diasporic heritage, that deference to the machine can effectively end up treating probabilities as though they were certainties or absolutes, in or out, all or nothing. I want to bring this back to American medical practices and public health practices. American medical schools teach that African Americans have greater muscle mass. Which was simply untrue, has always been true, but fiction dates to slavery, yet to this day affects how kidney disease is treated and analyzed by algorithmic calculations. Similarly, a test developed and endorsed by the American Heart Association weighs race in determining risk of heart failure. The algorithm automatically assigns 3 points for any non-Black patient. The higher the score, the greater the likelihood of being referred to a cardiology unit. Yet there is no rationale for making race a greater or lesser risk factor in heart disease, and the American Heart Association provides no such reason. Needless to say, Black and Black Latin patients with the same symptoms as their white counterparts end up being referred to specialized care much less often than white patients. So underserviced, too many Black patients caught up in assumptions, presumptions, and histories like this go unnoticed until they are at death's door with, quote, sudden, aggressive, unexplainedly aggressive versions of common diseases. And with endless irony, that is when those neglected bodies may become exceptionalized embodiments of genetic difference or comorbidities. Again, I raise these stereotypes in order to ponder the medical consequence of such epistemic foolishness at a moment when COVID-19's disparate impact and its toll on Black and brown bodies of color has directed much attention to these underlying conditions and comorbidities. And again, my concern about the degree to which they are discussed as innate, sometimes only impliedly, but nevertheless in the body. And given this attention to the fate of, I think that, this attention to the fate of people of color is really overdue. It's about time we started really taking it into account, but it's also double-edged. It highlights these inequities, but it also risks reinforcing them as innate. For example, if the United States' rates of infection of COVID are wildly off the charts compared to other nations, we do not generally blame it on the innate conditions of a peculiarly American biology. We know that these numbers are the products of poor policy decisions. And just so, disproportionate deaths among communities of color must not be attributed to an imagined separateness of African American biology. That is the risk. I also want to take this to imagine or to worry together about how race will intersect with the usages of vulnerability or assigned vulnerability for purposes of triage in hospital settings. With a shortage of ICU beds, race as a cipher for poor outcomes or underlying conditions that are then implied or assigned as untreatable or too late to be treated, these are already beginning to be weighted for algorithmic purposes because they are, after all, so efficient, and doctors really are quite busy these days. So indeed, on July 22nd, the advocacy organization Disability Rights Texas filed a complaint with HHS against the North Central Texas Trauma Regional Advisory Council for its use of a rigid, point-based algorithmic scoring system in the context of COVID treatments, which can automatically exclude from intensive care persons with a range of pre-existing conditions and disabilities without resort to individual assessment. And other states, I think, are beginning to re-examine their crisis rules in response to such conditions, and this is really good. I hope that this sort of re-examination and reconsideration is foregrounded in this time of pandemic. Finally, I want to say a little bit about the political consequences, if not the biological consequences, of treating race as biological destiny. So when some people speak of the China virus or the China flu, we not only give the disease a race and a place, we also give it distance. And this has public health consequences. It's over there, not here, well removed from the conceptual possibility of our susceptibility. If we are afflicted, it's not just the illness that debilitates us, but anger that we have been invaded by them. It is this form of displaced animus that one saw in the spikes of anti-Asian prejudice that arose in the wake of outbreaks of smallpox in San Francisco's Chinatown in the 1800s and that culminated in the Chinese Exclusion Act of 1882. Anti-Semitic nativism targeted Jews about typhus in 1890, or so-called typhoid Mary, disparagingly she was called, was an asymptomatic carrier of typhoid fever. Her arrest in 1907 on public health charges galvanized much anti-Irish sentiment in New York City, figuring Irish as immigrants importing unsanitary and slovenly habits. And when the AIDS epidemic first started spreading in the 1980s, some people told themselves it was a disease conveniently localized to the bodies of gay men. So instead of coming together around our shared vulnerability, time and again, we have created a set of golems to stand in for a pathogen, divisive demons that direct our fears of inherent virulence, murderous voraciousness, and leech-like parasitism. We see it now in the political sphere against Asians, aliens, anarchists, reporters, media, social media, even Dr. Fauci. People who wear masks, people who don't wear masks. It is as though we have been able to suture race, riot, and disease as ways to channel the existential fear to which we are all so vulnerable right now. If you could keep them out of your neighborhood, everything will be all right. And this, again, I cite as a public health danger. We Americans are not raised to believe in the entanglements of a common fate. And the very notion of public health is being undermined by ingrained brands of individualism so radical that even contagious disease is officially regulated by the vocabulary of choice, freedom, and personal responsibility. Many of us live in bubbles of belief that conceptual walls will protect us from things like viruses that are not easily walled. And these comforting bromides set us up for naive beliefs that disease invariably marks bodies in visible ways. Surely we'll be able to see it coming. You're fine if you don't have a fever. You can't spread it if you're not coughing. You won't give it to anyone if you're asymptomatic. So, well before this pandemic, we Americans were blinded by the walls of our privatized bunkers, our tribalism, yet the sense of entitlement which supposes that disaster will strike over there, but not in my backyard, pretty much guarantees an amplification of misdirected resources and relative disparities, racial segregation, but not self-preventative isolation, and from which everyone will suffer eventually. Thank you.
Thank you so much for that wonderful presentation. We are just waiting for questions to appear. And as we do you have any final comments, Patricia? Thoughts as we just wait for questions? And you are muted.
No, I do hope that, you know, there's an innate difficulty, I think, with the mission of public health, which is to look at us as in the context of epidemiology and of many, and to pluralize to some degree. And I hope we can disaggregate the information that data and statistics actually give us, as opposed to using convenient proxies and forms of pluralization that actually are stereotypes or are handy reductions that we then apply to social categories that have their history not in rational categories of susceptibility, but in historical fears of contagion and susceptibility.
All right, we got some questions, and thank you for that last point. Is implicit bias training embedded in healthcare professionals training?
I am actually unaware of how medical schools teach, or if they teach, questions of bias. I know that recently there have been a number of articles in the New England Journal of Medicine and elsewhere of medical students calling really calling their textbooks and what is taught in the classroom for some of its thoughtless, unscientific categorizations around things like, again, the spirometer, which measures capacity differently from whites, no biological basis, but which goes back to slavery. Lundy Brown has written a wonderful book called the infamous, it's about the infamous history of the spirometer. Dorothy Roberts has presented a TED talk about the miscalculation of creatinine levels having to do from calculations of assuming that Black bodies have greater muscle mass. Certain cosmetologists are reevaluating, I hope they are reevaluating myths having to do with Blacks having thicker skin and those sorts of things. These are, so I think we're at a moment when I hope we can discuss some of these both biological errors as well as, again, that affective sense of us not growing up in integrated or terribly cosmopolitan environments where we are across the board afraid of touch. And it seems to me that gets to some of perhaps what this questioner is concerned about in terms of implicit bias, the underlying affective response that one may not even be aware of. I mean, to some degree, we're all, unconsciously the product of our culture, and our culture has structures of thought that of beauty and of aesthetics and, again, of proximity that I think we need to discuss openly. So again, I can't answer specifically in terms of what goes on as part of a medical school curriculum. Again, I would point you to the research of Lundy Brown at Brown University, and I know that she has actually been looking at the way in which things like, I think, skin cancer is taught only against white skin as opposed to a range of skin colors, and but she's looking at the actual curricula and the degree to which some are just simply unexamined things that go back in history that nobody's bothered to re-examine or correct in light of real diversity in real bodies, or real diversity of bodies.
Thank you for that answer. Next question. During the pandemic of the typhus fever in the 1890s in New York City, quarantine was often applied to whole immigrant neighborhoods, causing social harm in the public eye. Do you think quarantine could have the same negative social impact in this epidemic?
I am quite worried about the fact that we are creating again almost these imagined bodies. We have bodies that are deserving, bodies that are undeserving, bodies that are marked as race, but we are also surveyed bodies, and our technology permits us to survey in all realms. I mean, everything we do, we're being surveyed right now through technology. But in the sort of exposure notification apps or tracking apps, contact tracing apps, there is a risk, I think, of repeating some of the habits of the past. And one of the things that I worry about a great deal is that this kind of monitoring in a pandemic ought to be done, but it ought to be done by public health agencies. And public health agencies have as a mandate privacy, not marketizing our data, not selling it for a profit, and not using it for punitive purposes. And I do worry that we are at a moment where the collection of data for ostensibly public health purposes risks maybe being used for policing functions. And so that's why when I read stories, for example, of particular police departments which are using drones to be able to take somebody's temperature at 500 yards, my question is, why is that in the police department as opposed to in the public health department? Because there would be protections and there would be ways of dealing with it as a health and medical concern rather than as a policing or geographic segregative or the function of policing in at least in our system is to locate and to confine public danger. But this is a human susceptibility, not just a public danger. And the idea of penalizing or criminalizing particular geographies, I think, is something for which we should be very, very careful.
Okay, next question.
Interrogate the kind of technology.
Oh, I apologize. I didn't mean to cut you off there.
I was done.
Okay. Next question. State medical boards often don't require continuing education in cultural competency or any associated topics. How can people advocate for changes in these requirements?
I think I do think that this is central to the question of how we're educated in terms and how we examine our culture. In the context of public health, I think that we have so many really unfortunate racial myths that routing those out ought to be the number one concern of what is biological, what is a cultural blinder. I appreciate the degree to which it's a politically vexed topic right now, that there is a thought that to even mention race is to invent race, or that to talk about it is to create that race and racism are the same. That if we somehow just don't talk about it, it will go away like a miracle. I am really hopeful that we can inform ourselves. And that, to me, I'm a teacher. It begins with education. And I'm a lawyer. And it begins with access to information and the ability to address inequalities and misinformation in ways that are motivated by anti-discrimination rather than sort of the three blind monkeys: hear no evil, see no evil, speak no evil, smooths over, rather than really allows us to get down to the very difficult conversations we have to have.
Okay, I think we may have time for one or maybe two questions, but if people's questions have not been answered, you can reach out to Patricia via the schedule a meeting feature in Pathable. Otherwise, I don't know, Patricia, you gave your email, but at least people can contact you via the schedule a meeting feature in our Pathable website. So the last question, or maybe the second last question, is what can legal service attorneys do to address some of these racial disparities? Right now, legal aid usually deals with access/coverage, but thinking about the social, political determinants of health, how can we get more involved to address the larger systemic issues?
Yeah, I mean, it's again, to look at why these disparities are occurring along racial lines is to look at the conditions of housing, the conditions of the access to health insurance and health care, food deserts and so forth. I mean, this has been said over and over and over again. I think that this is the consequence of both a history of conscious racial policies as well as unconscious, again, that aversive response in our society that makes us afraid of one another. But I also think that it would be helpful to look at other models in other countries right now of what has helped people stay sheltered, what has helped people, the kinds of economic subsidizing. We can dismiss it as socialism all we like, but there have been emergency interventions in parts of Europe that have prevented people from, massive numbers of people from becoming homeless. And it seems to me that that is something that we really need to examine and pursue as a political matter, as well as the question of legal legal remedies like anti-eviction, suspension of being kicked out of one's based on bills unpaid. That we're in this for a good year or so, at least. I would guess many years, and to view whatever our political response is as a kind of as an emergency. And we need to build the architecture of equity and fairness rather than simply to separate and to put everybody out on the street and then make them irredeemably lost souls. It will be very hard to reincorporate those into the greatness of this American experiment.
Thank you so much for your presentation. And now we're going to be moving on to our next presenter.
Thank you so much. That was fantastic, Patricia. Let me turn my video on so that folks can see me. It's really great to join you all today. I'm going to share some slides. And while I set that up, I do want to say that I've been following along with some of the dialogue in Pathable. And so as folks engage and ask questions, definitely please feel free to continue engaging with each other and providing responses to the conversation. So let me get this sharing. Okay, fantastic. Sarah, can you confirm that you're seeing my slides?
Yes, I am.
Okay, fantastic. All right, so I'm really excited to be joining you all today, and I'm so excited especially to be following up Patricia's wonderful talk. I think we have some really rich places for alignment. My name is Aisha Pamaku. I'm the founder of Movement Praxis, and I'm going to be talking today about a framework called the Civil Rights of Health, and diving into how it might offer us a way to approach COVID-19 and policy responses, as well as starting to explore a longer-term strategy to address oppression or subordination as the root cause of health inequities. So before I dive in, I do want to do some quick acknowledgements. The first being to Angela P. Harris, a professor at UC Davis Law School, who is a dear friend and collaborator, and we developed the concept of the civil rights of health together in an article that will be forthcoming in the UCLA Law Review. And this work has been supported by Change Lab Solutions, as well as the Robert Wood Johnson Foundation. And in the spirit of health equity and a lot of the care work that has been devalued and endangered during the pandemic, I'll also acknowledge my partner who is in the room right adjacent to me, taking care of our 4-month-old baby. So if you see my attention seeming to toggle back and forth, I'm trying to not have one ear listening to the baby. So with that, let's dive in. So today we'll be looking at an overview of the civil rights of health, who is involved in this initiative, and then how we might apply this framework to the present moment of crisis. And then we'll wrap up with some ideas where this work might go next. So let's get started with the concepts behind the civil rights of health. So I think, especially for this audience, it's very clear. Folks know that we're in a moment where our nation is facing at least 2 crises that are deeply intertwined. One is a persistent racial health gap that is in some cases widening, and Patricia has done a really good job of talking about how our racialized responses to race itself is kind of a collective fiction that we all participate in, and some of the dangers of that. And then also we are experiencing a crisis of institutional and structural racism, which has been dominating the headlines, namely in the form of state violence against Black people, in addition to state violence against other people of color and marginalized people. And it's these intertwined crises of a racial health gap and racialized state violence that have proved so difficult to address, so intractable, that two of our most powerful interventions, public health practice and civil rights law, have actually struggled to fully solve them. And this is because our nation's past and present expressions of racism have been so especially insidious, so difficult to dismantle. So it's our hope that in putting forth the Civil Rights of Health framework, we can start a conversation about addressing limitations in the legal tools we have, as well as addressing some of the roadblocks that are hindering the progress of public health research and interventions. So Angela and I have put this framework forward, and we call it the Civil Rights of Health. And really at its core, it's a call to partnership. And we are specifically calling on public health advocates and civil rights advocates to partner not only with each other, but crucially also with social movements for justice. And so this three-way partnership, we suspect, has the potential to protect the rights of marginalized communities, and so kind of have a reactive component, but also have a proactive component. So push our collective imagination towards bolder solutions for health justice. And so we argue in our article in the UCLA Law Review that one way to forge this alliance is to recognize that oppression is a health issue. And at its simplest formation, justice strengthens public health and injustice weakens it. COVID-19, of course, has given us a very clear and very devastating example of this, and it's showed us that pandemics, just like other disasters, actually thrive on inequality. So I'll start just by talking about the three partners in the civil rights of health and why their contributions are necessary to achieve health equity and racial justice. So starting with public health. So public health, of course, offers us evidence-based ways of addressing the spread of infectious diseases like COVID-19, and also powerfully with the social determinants of health body of literature, we have a way of understanding and addressing the ways in which health is influenced by factors outside of individuals' control, by systemic and institutional factors. Excuse me. And I think another thing that's so powerful about public health discipline and practice is it articulates a powerful goal, health equity, a world where your wealth, your status, power, zip code are all irrelevant to your longevity and how well you get to live. And so that said, despite its many successes, public health advocates have been faced with the stubborn persistence of unjust health disparities or health inequities. And there's many complicated reasons for this, but I'll just touch on three here. So the first is what we're calling universalism, which is that public health advocacy has, at least historically, too often focused on universal health interventions that may improve health for broad populations overall, but leave the racial health gap intact or leave the health gap for other marginalized communities intact. Another hurdle is individualism, which is pursuing public health campaigns of individual behavior change. And of course, the problem with that is that only focusing on individual behavior change can function as addressing the symptoms of discrimination rather than going further upstream to addressing the discrimination itself. And of course, this is often taken the form of encouraging individuals to make healthier choices, whether it's eating more produce or getting more physical activity. And so relatedly, there's an opportunity here to go further upstream and address oppression as kind of the root cause of unjust disparities in health. And because oppression is kind of a broad and unwieldy concept, we focus in on discrimination specifically as a concrete way of dismantling oppression. And of course, next we have another vital partner, the civil rights field. And just to clarify, when we talk about civil rights law and advocacy, Angela and I are honing in on anti-discrimination law in particular. And this is because anti-discrimination law has been explicitly and expressly designed to dismantle oppression by addressing the ways that discrimination appears in public and private in very particular areas. So everything from employment to housing to voting, Anti-discrimination law is very explicit in rejecting social relations of hierarchy. And it's also powerful because legal advocates in the civil rights space, they've long recognized that oppression is a driving force in creating and sustaining inequities. And so while we have the public health literature that sometimes can call inequities vulnerability or health disparity, we have the legal literature in parallel referring to discrimination, which has the power of recognizing that it's deliberately produced and perpetuated. So it gets us closer to getting to the root cause and naming the harm. And so civil rights law, as the body of law that has been developed to remedy discrimination, and we're looking to logically be an important and valued partner to public health efforts. And so our thinking is that together, public health and civil rights advocates can confront the obstacles that they face to achieving their shared goals. So then I'll just similarly quickly talk about some of the hurdles facing civil rights law right now. Civil rights law, of course, has been hampered by legal tools that essentially treat explicit interpersonal prejudice as the root cause of racism. And of course, this is problematic because this runs contrary to what we do know about how modern day discrimination functions as an institutional and a structural force. And there's a lot that could be said about this, but suffice to say, that's a major hurdle. And of course, various attempts to correct this have been met with different roadblocks that, to Patricia's point, see the treatment of individuals based on race as impermissible in all contexts, even if it is to remedy past racisms. And finally, just like public health, civil rights law has tended to operate in a silo, and there's a real opportunity here to align in anti-discrimination efforts. And one of the ways that we think that there could be some very rich alignment here is in the literature on the social determinants of health, which offers a way potentially beyond the disconnects that we see in public health practice and in civil rights law, because the literature on the social determinants of health documents and maps in a very tangible way how interpersonal, but also institutional and structural discrimination is decreasing the length and the quality of people's lives. And that literature measures this across different populations and different geographies. So COVID-19, while it is a moment of crisis, it's also an opportunity to train the attention of civil rights and public health advocates on the shared goal of fighting discrimination and doing so in the service of health for all. And this is what we're calling the civil rights of health. And finally, we turn to the third partner in the civil rights of health, which is justice movements. Again, really building on what Patricia has shared, we recognize that while an alliance of law and public health can and often intends to be a force for good, there is the need for an accountability partner to ensure that efforts for health equity and racial justice don't accidentally end up endangering and stigmatizing marginalized communities. So just looking at some of the opportunities available by partnering with justice movements, we see that justice movements, especially today, looking at the movement for Black Lives and other allied movements, have a catalytic effect. They provide the spark and the pressure necessary to catalyze policy change. And relatedly, they're also possibility expanding, which is to say they play a critical cultural role in expanding our radical imagination such that the public and policymakers become able to envision solutions that may previously have been thought of as outlandish, not feasible, or otherwise not on the table. As mentioned, they can be important accountability measures, and they also provide a very rich source of community data, or community intelligence rather, which is to say a rich source of data drawn from people's lived experiences on the ground, an ability to tell their stories in a very firsthand way. And of course, any sort of justice endeavor would be incredibly incomplete if it didn't center those most affected. And then finally, I'll note that we have seen justice movements step in to fill the gaps in policy and government responses. So for example, we saw the Movement for Black Lives Matter post a call for accurate and complete data at the intersection of COVID-19 and race. And we've seen other justice movements practice principles of mutual aid and create self-help networks in places where government response has let communities fall through the cracks. So to recap, we think that research on the social determinants of health can help make discrimination visible across people and places. And this is research that can enable civil rights advocates to seek systemic change in ways where they may have previously been stuck, and will enable public health practitioners in turn to equip themselves with civil rights law and understandings of oppression as a root cause of inequities to go even further upstream. So address discrimination itself as a cause of poor health. And of course, justice movements are a critical third partner to help educate and mobilize people power, as well as providing both an accountability partner and a catalytic spark. So then with that, let's turn to kind of the current moment and explore some priorities that could be suggested by a civil rights of health initiative. The way that Angela and I have been talking about the moment that we're in is as a wet cement moment. And when we think about systems and structures like racism, we talk about them as being hardened and difficult to change. But what we see is when we have these moments of crisis, they present brief windows of opportunity or malleability where social systems and structures can be changed for better or for worse. And what we've really seen is that when you have widespread disaster, whether it's climate or economic or health, not only do they usher in great hardship for marginalized communities, they also open the door to major social shifts. And the nature of those shifts often tend to be about which goods should properly be considered public and which should be considered private, which of course calls into question how they should then be managed. And we need look no further for examples in terms of, can an individual employer decide whether to give employees paid leave? Are people susceptible to eviction, making it impossible for them to then shelter in place and quarantine? And so we're really seeing that there's an opportunity here to press on the notion that more of the social determinants of health need to be properly considered public goods for the benefit of all, like paid leave, like quality housing, and that this is an opportunity to do that. And so if we look at this wet cement moment, it suggests at least two possibilities or priorities for us. One, pursuing anti-racist policy as a public good. And then two, hand in hand with that, is equitably enforcing law and policy. So, COVID-19, again, has really demonstrated the dangers of treating the social determinants of health as private goods that are reserved for the fortunate few. And we're really seeing that our collective ability to be healthy, to be prosperous, is entirely dependent on the least cared for, the least healthy, the least prosperous among us. And in that, we're seeing that our collective health, our collective welfare is very much intertwined. And so for that reason, we argue that this wet cement moment is an opportunity to talk about good jobs, quality housing, clean air and water, and even anti-discrimination policy itself as health interventions that both flatten the curve for everyone, but also close the gap between the privileged and the oppressed. And this, of course, is a very nascent conversation, but one where we're seeing some very promising momentum. And also, I'll just briefly note that to one of Patricia's points, one of the key barriers to this is overcoming the harmful narrative that we often see underlying policy decisions, which is this idea that some people and places deserve good health, while others do not deserve that. And of course, this is a very old policy philosophy that goes back to how we manage and make policy around poverty. And so, we are seeing some real traction in this. Namely, we're seeing communities across the country declare racism a public health crisis. And so there's really recognition growing that the harms of racism are far-reaching, but they're also of concern to the whole community. So we propose that this is a good time to use policy to confront systemic racism as a collective good, a public good, but also as a direct challenge to the narrative that there are some who are deserving or undeserving of health. So in this way, we look at anti-racist policy both as a public good and one that is foundational to health justice. We look at that as opening the door to treating health and its determinants as something that should be managed as a public good for the benefit of all, which of course begs the question of how are we enforcing these policies? And as the movement for Black Lives and its allied movements have taught us, there really is no such thing as a race-neutral policy, and that the goal that we should be looking at is anti-racist policymaking. And anti-racist policymaking, of course, begs the question of what does anti-racist, what does equitable enforcement look like, even when looking at seemingly race-neutral laws. And so part of the problem with enforcement, of course, is that in addition to enacting violence against marginalized people, unjust enforcement also has an economic dimension. So as we saw in Ferguson, Missouri, local government has sometimes sustained itself through penalizing those who can least afford it. So the issue of enforcement is both one of public health and racial justice, as well as a question of community investment and correcting decades, generations of institutional and structural disinvestment. And so really, instead of biased, extractive, predatory enforcement, we're exploring the question of what would enforcement look like if it was guided by principles of racial and health justice. And that is very much an open question and one that we're very interested in having ongoing dialogue about. But we think that, it's really important to continue circling back to justice movements who have been pushing the conversation in this, especially like the movement for Black Lives, who can really be partners in helping public health and civil rights advocates explore a new enforcement paradigm that is health promoting, that is equitable, and that is explicitly anti-racist. And so just to recap, in this wet cement moment, we look at anti-racist policymaking and equitable enforcement as a way to bring us closer to dismantling discrimination and addressing unjust health disparities. And we think that this three-part alliance, public health, civil rights, social justice movements, can lay the groundwork for making and sustaining that paradigm shift. So with an eye on the time, I will just end with some reflection about how the civil rights of health might take shape over the coming months and the coming years with an interdisciplinary coalition of collaborators, and just kind of acknowledge that this work is very nascent. Angela and I have developed this work very much with the hope of collaborating with folks, and that other people will bring their best ideas to the table and help us figure out how to apply this framework. And so much of this is a repeat of what we have expressed in the COVID-19 policy playbook, but there's a couple of priorities that we can explore at this moment. One, of course, is effective data collection. You can't manage what you don't measure. And also, to Patricia's point, is making sure that we're contextualizing data such that it doesn't exist in a vacuum, and such that it doesn't allow people to tell harmful narratives about race and its function in health. We can also pursue questions of budget realignment, which is absolutely tied up in the question of anti-racist policymaking and equitable enforcement. We can pursue a targeted universalism approach to policy development, where we look to benefit the most marginalized and then apply that policy universally across all populations, so that the marginalized disproportionately benefit, but all do benefit as well. And last, we can not last, but second to last, we can also link unjust health disparities with the systemic discrimination And this is, in some ways, it's a philosophical leap, it's a narrative leap that's the precursor to taking policy action in an anti-racist way. And so I really think that one of the very promising ways forward here is a lot of these local declarations of racism as a public health crisis. We're really starting to see those linkages come together. And then, of course, finally, we should be partnering with justice movements as an accountability partner and a catalytic spark. So then, these are just some takeaways from where the civil rights of health work is right now. Just this three-part alliance: public health, civil rights, and justice movements. How we can work together to get beyond our stuck points, and how we can look at this wet cement moment as an opportunity to of course, care for those who are most marginalized and who are falling through the cracks, and simultaneously to take the proactive approach of looking at more of the social determinants of health as necessary public goods and frontline health defenses. And then last, prioritizing not only the creation of anti-racist policy, but equitably enforcing it. So with that, I will thank you all very much for your engagement and attention. And of course, invite you to keep the conversation going, as this research is very much ongoing and in development. So with that, I will take a look at the chat box here and look at some of the questions. And again, if folks who are in the virtual room have their own answers to the questions, please do chime in. I'd be really interested to see some engagement. One question: are there communication strategies to get the public on board with a more collective view of society rather than an individual view? Oh, that is such a good question. Yeah, I am very much of the view that our collective imagination and how we talk about things is the precursor to policy change and not the other way around. Generally speaking, I don't think we make policy and then suddenly learn to talk about things, think about things differently. And so I think there are a couple pieces to the communication. I will just give a shout out. Actually, I know the De Beaumont Foundation just put out a really great communication guide to public health and COVID-19. So I think that's a great resource. And then I also think there's really something to be said for giving people the data and contextualizing the data. One of the things that I've seen to be the biggest risks in terms of a lot of my public health data heads, of which I am one, is that we tend to assume that if we just inform people about what the data says, the logical conclusions will follow. And I, again, to some of Patricia's earlier points, I see that we increasingly need to contextualize the data to help people make sense of it in terms of systems like structural racism. And Sarah, I can't see the time. Can you give me a quick time check?
We have maybe time for one more question, and then I have to end it.
Okay. Let's see, there are such good questions here, but you all have my contact information on this slide, so please don't hesitate to reach out to keep the conversation going. Let me see what I might be able to answer last.
What about this one? What specific
Thanks,
policies
Sarah.
or types do you think might be the most promising to improve health?
Can you repeat that?
What specific policies or types do you think might be the most promising to improve health?
Specific policies or types. A couple ways to slice that. I think in this current climate, one type of policy is just simply local policy. I think that's where we're seeing a lot of innovation and promising best practices, like the declarations of racism as a public health crisis. And I really increasingly look to local governments and increasingly coalitions, regional coalitions of local governments as pushing the next phase in this work. And you know what, I'll leave it at that, but which is just to sort of reiterate a lot of my faith in local innovation, particularly in this context, and then just end with a note that where policy innovation is deemed not feasible or not possible, I always encourage folks to look at questions of implementation and enforcement which is often where there can be traction and can be major and measurable progress in people's lives. So I will, again, thank everybody for your engagement, and I'm sorry we didn't get to more questions. These are some very pressing and interesting questions in the chat box, but I'll hand it over to you, Sarah. Thank you so much for moderating.
You're welcome, and thank you so much for that presentation. Okay, so that concludes today's session. Please press the button underneath this video feed in Pathable to take the evaluation. Thank you again for attending, and have a great rest of the day. And thank you so much for our presenters.
Thank you, everyone.
Thank you.